My name is Jason Noel. I'm Deputy Director of the Placebo Beyond Opinions Center. And we are a research center here on the campus of the University of Maryland, Baltimore. We're committed to moving beyond mere opinions or assumptions about the placebo effect and delving into rigorous scientific investigation. Our name emphasizes the center's focus on advancing beyond subjective beliefs or unsubstantiated claims about placebos, instead aiming for deeper understanding through empirical research and interdisciplinary collaboration. The term beyond opinions refers to a departure from speculation and a dedication to evidence-based inquiry. So these are our goals to advance interdisciplinary research and education on the placebo and expectancy effects, to work with global leaders to investigate the placebo effect and their impact on symptom variability, treatment responses, and clinical encounters. And PBO seeks to improve clinical trials, educate future clinicians, and integrate placebo knowledge into precision medicine practices, ensuring optimal patient care. We're pleased today to have the second lecture in our spring guest lecture hybrid series. Please do plan to as well attend our upcoming lecture on April 28th. But we are in for a treat today, and I will turn it over to Ioana to introduce our speaker.
Thank you, Jason. So we mentioned that our intent is to attract global scientists and personalities. So we have here a global expert on chronic and acute pain. So Professor Stephen Cohen is coming from Chicago, where he is currently a full professor of anesthesiology at the School of Medicine. He also served as the director of the pain research and professor at Walter Reed National Military Center and the Uniform Services University of Health Science. So previously he had several faculty positions, including one close by at Johns Hopkins. The reason why we invite him is for his research is one of the most cited researchers for pain, and he published on Lancet, JAMA, New England Journal of Medicine. But also he served the critical population like military. He was deployed and he served in Afghanistan, in Bosnia, in Ukraine, so making his work truly translationable to the battlefield, to patients and daily life. So with this, I would love to invite Professor Cohen to the stage, and please welcome.
No, let's switch file.
So this is what I'm going to talk about: challenges in design and interpretation of clinical trials, really more for interventional pain medicine. And I probably should have showed that image that I saw for that I just sent you, or that I just showed you. So these are my disclosures. Nothing is really relevant to this talk, although I will discuss a little bit on neuromodulation. SPR makes peripheral nerve stimulation. That's not discussed here. And at the end of this talk, I hope that you can understand the effective perspective as on the evaluation of interventional pain outcomes, understand differences between efficacy and effectiveness, learn to identify and maybe mitigate different forms of bias, and understand the limitation of placebo-controlled trials, how difficult they are to perform, and their generalizability. Did I think there's a little echo. That's fine. So the first time that I really understood the effect of perspective, I was in New York City. I was a medical student in Manhattan, and I would get the New York Times. And in the science section of the Times, which would come out on Tuesday, they had this big thing, and it was basically saying that the Philistines were not only more probably technologically advanced than the Hebrews, but they might have been more culturally advanced than the Hebrews. And this blew my mind. This was the first time I ever thought this, because I thought it was almost that it was so widely acknowledged. And why would it be so widely acknowledged? And it's because really, the only writings that we have are the Bible, right? Writings from the Hebrews, and the winners write history. So you can see here, David slaying Goliath, who was, either 6'9" or 13'9" tall, depending on it. Samson pulling down the columns of the temple after being betrayed by his second Philistine wife, Delilah. And this is what it's like really for pain medicine. So if you saw this recent BMJ review and guidelines, this is so heavily criticized among interventional pain physicians. I mean, almost universally. And you can look and you can see a lot of bias. They really didn't have an advocate. And if you're, a pain doctor or you're a spine surgeon, most of the things that come out in the general medical literature or in the Washington Post or the New York Times, are really negative. But everything that you see in specialty journals is positive, right? You definitely have this big bias. And so this was the 2018 Lancet Low Back Pain Group. It says, although the UK guidelines suggest consideration of radiofrequency ablation for back pain unresponsive to non-surgical treatments, the negative MIN trials challenged this recommendation. And then there was even more controversy about the letter, because they were recommending this group, not recommending never doing this outside of the clinical trial. And I said, you gotta be kidding me. And so I said, to include everyone except for me on this. And it kind of changed a little bit how we did it. But fast forward a few years, this is part of a Lancet pain series, and then a Lancet back pain symposium. So I'm also on these, and we come with very different conclusions, right? But it's the same journal. The first one, RFA of the cervical lumbar facet joints, SI joints, and the knee, and I'm involved in all of those guidelines. It was chair. It can provide relief, but you really have to select patients very carefully, and technique is very important. And the same thing here for the bottom one. And it really addresses the MIN study, and it brings up nice guidelines and says, again, if you select patients carefully and you maybe do it properly, and that's kind of a big part, as I'll show you. This is from, to be a pain doctor, there's lots of different ways. You can be emergency medicine, you can be a psychiatrist, you can be a neurologist, you can be a physiatrist, you can be an anesthesiologist, you can be an interventional radiologist. But there's also many other different things. There are so many people who are family practitioners. The one thing I'll say is that we don't have a lot of interventional radiologists, and they are kind of like anesthesiologists. They don't see patients, they do procedures. And so they do different fellowships. But you can see here, this is from radiologists, and it's very simple. The set joints constitute a common source of pain, 15 to 45%. Well, probably there's no population in the world that it's 45%. It's different. The step blocks can indicate the set joints as pain, but there are many kinds of step blocks. You can do medial branch blocks. It's very simple. And they say, well, you can do all of these different things. Facet joint neurolysis, not even sure what that means. Radiofrequency cryoablation, not a lot of evidence for cryoablation, and it will give you benefits. Very simple. Like the Tale of Two Cities, this is a tale of 3 studies. These are on radiofrequency ablation. It's important because it's the second most common interventional pain medicine that's done in the United States. So the LeClaire study, right? So if 10% or 10 to 15% of people have lumbar facet pain, and you do a trial and you screen 76 people, you know, there might be 10 people who actually have facet joint pain. But they did these procedures and almost everybody entered the trial. So there's something the matter there. What they did didn't make a lot of sense. They said, okay, you have to have significant relief with lidocaine after a block. Intra-articular blocks are definitely not as predictive, right? If you want to know if hurting a nerve is going to work, you should block the nerve, not the joint, and there's a high technical failure. But, you know, older guidelines said, you know, with lidocaine, it's very, very short acting, right? People have had lidocaine maybe in the mouth before dentist procedures. If it lasts more than 7 hours, the old guidelines from Ipsos used to say you're way more likely to be a placebo responder than a true responder. The study was negative, and they used to use the old methodological quality score by Jadot out of 5, and then some kind of clinical relevance score, which is not really validated, out of 9. And so this got very high scores. There was a later study by NAF, right? They just very small study, 40 patients. But to get these 40 patients, they screened 376 people who were really, really stringent with their criteria. You had to have 3 medial branch blocks and you had to have 80% relief. So probably a lot of people who might have benefited were not included, but who cares? This is an efficacy study. And they created 6 lesions. They didn't stimulate. We had done a study that showed that stimulation did not really predict outcomes, and radiofrequency was better, and it gets lower quality scores. Then the MIN study published in JAMA, not really an efficacy trial. It has the lowest quality scores. The lowest quality scores are on the bottom. Let's see, over here. And you couldn't enroll in the study in the Netherlands. It was sponsored by insurance companies who might have some bias. People could get exercise, they could get psychotherapy, they can get analgesics, and they were just comparing really add-on radiofrequency ablation. Over 70% of people had positive blocks. They just lesion the same levels in everyone. Right? So the set joints are all up and down your spine, so it's not really personalized. They created very tiny lesions, and they later said, yes, we probably shouldn't have done that. And there were differences, but they were not significant. So these are differences in some of the studies. So we all know what the methodological quality, right, entails, right? Are subjects blinded? Was blinding assessed? You know, are you avoiding selective reporting? But there's a lot of things for you know, technical things that people don't consider. this is why you have to have some kind of interventional pain doctor. This is from something called Aquarius that we had done. We had a few editors in chief journals, right? The technical thing for epidural studies, right? And I think Luana was at the Vertex meeting last week, but you were discussing the placebo. You didn't hear all the intense discussion of MRI. But basically, if you don't have MRI findings that correlate with pathology, you do really poorly. In fact, you won't even be able to get like surgery. Are we avoiding people with psychopathology, with secondary gain, with non-organic signs? If you want people with radicular pain, you know, you need to have leg pain more than back pain. It should be neuropathic pain. You don't want to include people with pain for 10 years because they're going to have, they say, a lot of central sensitization. But you also don't want to include people who have pain for 4 weeks because they're going to get better no matter what. And you should kind of standardize the injections. So this is something I see this slide a lot. This probably took a few hours to put together. It was in a article. So this was, at the time, there were a little bit less than 50 randomized trials for epidural steroid injections. And if you just look at the corresponding author, if it's a pain doctor who does epidural steroid injections, 75% of the studies are positive. If the corresponding author is not a pain doctor, then it's about 30%. So it's a big difference, and you can say, well, you know, I do these procedures, right? Maybe I can do them better, maybe I select patients better, I do it the right level. But if you look at either systematic or evidence-based reviews, and this is what I was commenting on this afternoon, it becomes really hard to reconcile this because you're looking at the same studies. You're probably using the same criteria, right? Like grade criteria or something. And almost every review, evidence-based or systematic review, and we're talking way over 50, probably close to 100 on this. Almost all of them are positive if it's done by a pain doctor. And if you just look at the BMJ paper, about 1/3 are positive. So this is really hard to kind of to reconcile. And I'll say this was never published. This is spin. Spin is exactly what you think it is, right? Like you're saying, this is positive when it's really not positive, or you're reporting secondary outcomes and saying this is a positive study when you really should be reporting primary. It's exactly what you think. Almost all studies looking at radiofrequency ablation and epidural steroids, there's not a little bit of spin, there's a lot of spin. So it's really hard to even say what's a positive study. I'll just give you some stuff that we're interested in, right? This is spinal cord stimulation. Spinal cord stimulation is something that the NIH and the FDA is very interested in because there's a huge discrepancy between clinical trials sponsored by industry, and almost all of them are because it's so expensive, right? So to do a trial, when you're looking at a device that's costing almost $30,000 to put in, and you're trying to do a study, who's paying for it? So this is something from spine surgeons. It's with paddling. So surgeons do it because they do a laminectomy. Preoperatively, 76.6% were on opioids. Postoperatively, it was actually higher if you had a spinal cord stimulation. This is a study that we did in JAMA Network Open. We propensity matched for everything. We were looking to see the most common indication of spinal cord stimulation put in with people who had previous spine surgery, if it reduced opioid use. And when you have 700,000 people, every tiny little thing should be positive, but it wasn't at all. There wasn't even a signal that it reduced opioid use in these people compared to those with the same diagnosis who were matched and didn't. And the difference was so small, about 1% with spinal cord stimulation, people who were less likely to start opioids, right? You can say, well, 1%, that's important for those 1%. But really, if you kind of understand spinal cord stimulation, it's probably not even meaningful because a lot of people get spinal cord stimulation because either they, under no circumstances, want opioids, or their doctor refuses to give them opioids. So you really have almost no benefit. The Druva study, right? Another study in JAMA Neurology. It was a propensity match study, 7,560 patients. And first year after spinal cord stimulation, people were more likely to be on opioids than those who didn't get it, but they were less likely to have epidural steroid injections or radiofrequency ablation. Second year, nothing, no difference in anything. But you look at this systematic review and meta-analysis, right, where they look at randomized trials. Almost all of them are, 4 of them are sponsored by industry, and the one that's not, they all have lots and lots of disclosures. And look at the odds ratio, it's unbelievable. It's kind of suggesting, it's very small, right? But boy, if you get spinal cord stimulation, you're not gonna be on any opioid. So it's not really what you see in real life. And this is something, in the Cohen library, and I don't agree with this because it's not based on a lot, but the Cohen basically says nothing works. That's the problem, right? If we just went by, Cohen database systematic reviews, it would be nothing. But they say, at 6 months, the only available evidence for spinal cord stimulation was from a single crossover trial. So there's moderate certainty evidence that spinal cord stimulation probably does not improve back or leg pain. I'm not sure how you can draw that conclusion. But the interesting thing is, they had an editorial, and this is exactly from the editorial. And so what happens is you see the same thing, right? There's many letters, right? There's 18 letters that are published, and they publish them all in journals, and everyone is critical. And I've looked at a lot of these studies, right? You are very critical of negative studies, even if there is methodological or technical flaws. And then, but a lot of the positive studies have the same flaws, but nobody ever criticizes those. And so they were basically saying the usual thing is, rather than respond to the journal where the study was published, they published in other journals. So 15 out of 18 letters, they all criticized the study, and they were published in other journals where the authors were like on the editorial boards. I won't get into this, but this is like new drug applications for treating chronic pain. Only 21 of 39 were supported by at least a pivotal trial. I don't knock, them having a median duration of 84 days. It's really hard to justify keeping people in a study with chronic pain and they get a placebo group and they get more than 3 or 4 months. I get that. But 81% of products were approved on base of designs that excluded patients who couldn't tolerate the drugs. They had early AEs or they reported few immediate benefits. And I'll show you slides, but I think Dr. Kaloka has an even better slide than this about like different enriched designs. And so the thing with like these enriched designs is there's some evidence that they can increase the chance of a positive outcome. If the FDA will accept it, you're a company, you're beholden to stockholders, you should do this. The problem is they're not really generalizable. And if you look at like opioids versus non-opioids in this graph here, you have pretty strong evidence that opioids really aren't better than non-opioids, especially for function. So I showed you a lot of database reviews, right? Like ours with over 700,000 people. So database reviews are amazing, right? People are using these all over, like with even millions of people. So the issue is, they provide some information on associations, but not really cause and effect. So like opioids, no matter what you look at, right? Every single interventional procedure for chronic pain, if you are on opioids, you're more likely to fail. We have a paper coming out in BMJ Medicine on it, and there's something by a guy, Yergeny, a systematic review, and they write, opioids were overwhelmingly, this is what they write, associated with negative, pain, functional outcomes, complications. Problem is, if you did a randomized trial, so you would definitely see that opioids are more likely to be associated with negative outcome. But what if you did a randomized trial and people got a procedure or they got just standard medical management? You might find that opioids were even more likely, like 5 times more likely to fail. So this is what you saw in the sport trials, right? The sport trials were a whole bunch of articles. They were published in New England Journal of Medicine, JAMA, or all these amazing journals. They basically were NIH funded, and they compared surgery to standard medical management. Lots of people crossed over. They're very, very, very sloppy studies. And what you found was that obese, and now they call it severely obese, patients were more likely to fail surgery. Got it. But because these were randomized trials, if they were randomized to not get surgery, or if they didn't get surgery, because there was a high crossover, right? They were way more likely to fail non-surgical treatments. So if you're looking at it in the context of a randomized trial, you're going to say, maybe overweight people should get surgery because they're going to fail everything. And like I said, we're also looking at prehabilitation now, like in this new article, and you don't have a lot of evidence for prehabilitation and weight loss. In fact, being overweight, you fail treatments, surgical, non-surgical, interventional, non-interventional. But there's actually some data, this is beyond the subject of this talk, that if you lose weight before joint replacement, that you might have more complications than if you don't. So it's a really complicated thing. So these are how statistics can be manipulated. And I'm going to show you some, some personal examples. So this is a study that we published in Annals of Internal Medicine. I don't know if this is true, but I will say that Annals of Internal Medicine likes to say that they are the statistically most rigorous medical journal in the world. I don't know. So this went through like 7 revisions. And when we first submitted this, we used Hanover. Everybody knows what that is, analysis variance. And you can see, epidural steroids compared to epidural etanercept cytokine inhibitor and saline, the p-value is 0.07, so it's very close. And then the journal comes back and say, we wanted a little bit different analysis. And the Audrey Chang was the chair of the IRB at Walter Reed, and she was a PhD statistician. And so she says, I'm going to do this thing, multiple regression. And she does this analysis. You can see what the p-value is. And we send it back to the journal, and they say, we'd like to have a meeting. And they put their statisticians on the phone. I kind of recused myself, even though I was the principal investigator. I said, I'll let the statisticians, we had two of them, Ralph Larkin's also a PhD, and they all decide on ANCO, but we don't know what the results are. But when you read the results, they're 0.24, so it's like barely in trend. So this is the same data. And so this is from the New York Times, and everybody has bias, right? Because Nick Bacalard, this was, I think, the second article, or the first of two articles that he did on work that we did both on epidural steroids. He had 3 epidural steroid injections. This is what he said. He didn't get better. He probably shouldn't have had any. So everybody has it. I spent like 30 minutes, talking to him about the statistical plan, read the discussion, but it doesn't matter. Just right, steroid shots are more effective than placebos. It's very complicated. So these are differences between efficacy and comparative effectiveness, right? Efficacy is highly controlled, very methodologically strong, very long list of inclusion and exclusion criteria. They might cost like easily over $30,000 for one patient, or $35,000 for one patient to enroll. But comparative effectiveness studies could be basically free. You're comparing two things, right? You want much more liberal inclusion and exclusion criteria. You want more sites. You want longer follow-ups. For efficacy studies, you want the best practitioners. So this was a big discussion at the Vertex meeting. Who should we have? Should we have only neurologists? Like there were a lot of things, and there were more neurologists there than me, but I think they're going to be very inclusive. Comparative effectiveness studies consider things like utility, speed, tolerability, sustainability, and cost. So you really want like longer follow-ups. They can result in false negative results for an efficacious treatment. So you have to be very careful. You want to ideally establish efficacy first, but they more closely represent real life decisions. But a lot of these things, like the best practitioners, ideal patients, they're not relevant. You don't care about those. Efficacy studies, of course, always, sometimes profoundly overestimate benefit in real life, right? That's the spinal cord stimulation stuff. Very quick thing, right? It's hard to even say if a study is positive or negative because of all that spin, but these are radiofrequency randomized trials. And basically, if you want to see if a study is positive, you have to select patients better. So positive studies, if you put them all together, right, they are a little bit more than twice as selective. All right, going back to the next thing, right? So Luana was very kind enough to give 2 lectures. This is like amputations in the Ukraine, Russia war. This was basically one year ago, over 90,000. And there's a lot of controversy as to what Ukraine says, their government, and what NATO estimates. They don't have pain specialists in the country. And then the 2022, 23, 24, and now 25 National Defense Authorization Act say that you have to study post-amputation pain, so this was a really good thing. So I'm not going to get into hydrodissection. We don't have like people who are anesthesiologists, but basically hydrodissection is really easy to do. It's very, very cheap. Anyone can do it. An anesthesiologist can do it. An obstetrician can do it because they do ultrasound, or a cardiologist or anything, right? There are certain ways that it might work. We did a study. War is very complicated. Basically a prospective, and was registered, but with the Ukrainian database. So the World Health Organization wants databases in English. Small study, 45 got hydrodissection, 41 got only opioids. There are a lot of baseline differences. So I'm saying this is not a really strong study. And a lot of the differences kind of would favor the hydrodissection group. Like they're a little bit younger, they have shorter duration of pain, they are very slightly lower doses of opioids. And without getting into the specifics here, right? Hydrodissection, it's when you inject high volumes of fluid around neuromas, right? So if you cut off a leg, you're going to get a neuroma, the sciatic nerve, femoral nerve, lots of other nerves, depending on where you cut the leg off. And it seems to work It seems to work better for pain in the stump or the residual limb than in the phantom, and it works better for acute pain than for chronic pain, because you might be less likely to have scar tissue form, and it might wash out these like calcifications called heterotopic calcifications, which are really common after specifically traumatic war-related amputations. And there seems to be some signal that they reduce opioid use and that they might reduce combined anxiety, depression, so together without separating them. So we submit this. I'm very conservative. I say I want the most conservative possible analysis, and I want the most conservative interpretation. And it's basically negative, in multivariable analysis. In that top slide, it's negative. And we send it to, the organization that I sent it. I was very nice because in, just like 6 weeks or 5 weeks, I'll be the president of Ashura. So we have our own journal. I wanted to send it over there. And they wanted a different interpretation. They said, yeah, we agree. We like very conservative interpretations, but we think that you're really going overboard. And this is how we would do it. They didn't know what the results are. And then you see it's kind of a little bit positive. It says, well, hybridissection, probably works, but it works better for residual limb pain and it works better for people with acute pain. This was a really big thing. So I don't really keep track of this. This is BBC TV World News. It was on ABC affiliate. Washington Post is going to do something. It's been on like Science Daily and all these things. My medical student said this is the top 5% of all time like articles on altmetrics. So I don't really check. And it was in a decent subspecialty journal, so it's not great. So everything depends on how you analyze this stuff, right? Because the same thing with that Annals paper, the same thing with this paper. Like these are negative, positive, and then they're analyzed differently. I feel guilty talking about the placebo effect. I can go through these real quickly, to this audience, because everyone in this room probably knows more about this than I do. But the placebo effect is so big for pain. It's big for really everything with subjective outcomes, so anxiety, depression. We're into this thing called intersectionality that I was saying, right? It's really hard to separate these things in multivariable analysis. Lots of different things are predicted. The ones that are very relevant here for pain things. Procedures more so for pills. It's a myth that that the placebo effect is always very, very, very short lasting. It depends a lot on expectations. And just a couple things, right? This is a really quick thing, right? So for procedures, absolutely, right? The placebo effect, and it might have to do with expectations, right? But the placebo effect is stronger for procedures than it is for pills. I won't get into all the different possible reasons that is, but that is a fact. And you guys know, right? With a strong placebo effect, it makes it statistically difficult to detect the same absolute difference. So if you have a difference, a very small difference of 1, well, it's easy to detect the difference between 2 pounds and 1 pound than between 11 pounds and 10 pounds. And it's really hard, as a doctor who sees patients, because I want people to think that they're going to get better. I want them to have very high expectations, but it really borders on malpractice if you're not telling people the truth. Like you shouldn't give them false hope and expectations, because then they have procedures that are not likely to help them. It's a balance. And look, again, very quick, right? The placebo effect for lots of different things is greater than the intrinsic effect. And this is not just for drugs, this is for injections, this is probably for surgery as well. And if you look at least some studies, right, like in differences in grades, right? Like if someone gets gabapentin and someone gets placebo, well, the difference between gabapentin responder and a non-responder is going to be greater than the difference between a gabapentin responder and a placebo responder, right? So it's probably then. this is the issue that we have, right? Like, what is sham acupuncture? Is it needle at wrong points, at non-points? Is it if you don't stimulate? Is it just going at points but not penetrating? This is a huge thing I'll go over, epidural steroid, that you have to kind of appreciate. And I will say that our group was really the first to kind of point this out. When we're doing, radio frequency ablation studies, you have to do blocks, because otherwise people are going to know without a doubt that they're getting a nerve burn. And you're giving steroid also because that might reduce neuritis. They're really getting nerve blocks with steroids. The vertebral augmentation studies, were criticized because these people all got basically facet blocks, right? The local anesthetic in all these studies. And without getting into it, but if you get a vertebral fracture and it's a posterior fracture, the facet joints collapsed on each other. So it's a very common source of pain. And the same thing for like joint injections. These are some ways that you can do things. Like I say, you can minimize staff interactions. This is a big thing. Shorten or lengthen study. The evaluator should be blind and independent. So, pain scores are not really linear, right? So now there are a lot of people, the really placebo researchers, they're saying, maybe you shouldn't even include people with 9/10 pain. Everybody excludes people with 10/10 because regression to the mean, almost 50% is a placebo effect. So if you have people with 9/10 pain, they're going to be a lot of placebo responders. But when I look at our studies, right, if we allow people between a score of 4 and 9 to get into a study, it's not close to normally distributed. Everyone is clustered around 4 because like these centers, they want to recruit patients. I mean, a lot of the CROs, like this is their livelihood. They have to recruit patients or they're going to close. You can't send your kid to college. You can't afford the mortgage on your house, and you want to avoid people with wide variations in pain and psychopathology, right? Wide variations in pain are definitely associated with a placebo response, but even if they're not, it makes it statistically harder to show a difference, right? Because the standard deviations are high. So this is the study that we had done. This was also in the New York Times. Background on epidural steroids, right? Epidural injections for back pain were being done in the 1890s. And the first reports were in French in 1901. And then for decades, people were just using epidural injections for back pain. The first just reports on steroids for back pain were in the 1950s. So people were using them for 60 years. And then everybody kept using just epidural local anesthetic for back pain. And it wasn't until the 1970s, early 1970s, that the first randomized trial compared epidural steroid to some kind of control. Now somehow, right, like I said, there's been way over 50 sham controlled trials, and they just keep coming out. We have one that was just published in December. And for some reason, and this was lost on everyone in the population, they started to consider epidural local anesthetic, which for decades was used to treat pain, as a true placebo, right? So some people for the placebo just get intramuscular injections, and some would get epidural local anesthetic, and some would get epidural steroid. And I was saying, well, boy, if epidural local anesthetic really is not a placebo, then these studies are going to be more likely to be negative for the effect. And without getting into this, if you look at the first follow-up, more than half of an epidural steroid injection effect has nothing to do with steroids. It just has to do with just doing an epidural injection. And you see the same thing for just steroids for other treatments, right? By Shantano, right? If you add steroid to local anesthetic, you have to treat 13 people for one person to get meaningful relief. And if you remove these two outlier intrathecal trials, you have to treat over 20 for one person to get relief. So this is a really hard thing. Like what should the thing? And this is some of the things that we went over, right? Like what you want to do, right? You want to get population that can respond to a treatment, which is enriched. And you want to also at the same time eliminate placebo responders. So how can you do this? This is something on the left that's theoretical, and this is something that was done by Ho in 2019, right? Gabapentin and tramadol versus placebo. Probably, out of the 59 people enrolled, 41 were excluded. 5 just because they didn't respond to gabapentin, and 23 because, there was a failure for their pain to return to baseline on placebo. So it's very hard. I show this, right? Everybody knows this. Everyone has seen this many times, right? This is the BMJ Christmas issue, right? Parachutes reduce the risk of injury after gravitational challenge, but their effectiveness hasn't been proved with randomized trials. But fast forward 14 years, and they did a randomized trial, and parachutes didn't work. But the devil is in the details, right? Because the planes were on the ground, they hadn't left. That's why it didn't work. And this is what I say to people, right? If we do radio frequency and we say that burning pain nerves works, then it's going to work better if you actually burn the nerve than if you don't burn the nerve. So maybe a larger lesion would work better. You probably don't need it, right? Deductive reasoning is when the conclusion is a logical consequence of the premise. So let's say that decompression surgery works, right? We all think that there are some people that should get this, it should work, right? And we accept as a premise that decompression surgery works better if the surgeon operates on the correct level, right? That he operates on the wrong level, right? That's a pretty fair premise. Well, if you can do something to increase the accuracy of diagnosis, like a selective nerve block, could be anything, EMG, nerve conduction studies, you don't need a randomized trial, right? Absolutely not. And in fact, none of them have been done. But inductive reasoning is different, right? Because that's moves from a specific set of facts to a general conclusion, right? If traditional auricular electrical acupuncture works, it doesn't mean that every kind of acupuncture works. There's lots of things that are not amenable to placebo-controlled trials, right? Like rare complications, like a pneumothorax after acupuncture or death after a cervical transfer. You can't find it on clinical trials. You need these database reviews. For the same statistical reason, something with a very, very high success rate, right? Like if you had a better treatment for appendicitis, well, everything that, all surgical procedures are pretty effective. I mean, the problem with, surgery is that lots of people probably didn't need surgery. Ultrasound makes it a little bit better. Or a condition with a very low success rate. So you can have something that works for pancreatic cancer, but if your outcome is 10-year survival rate, you won't see a difference. And then you have ethical things, right? Like, the Tuskegee experiments, right, for syphilis, where, you're trying to see the natural course. Guidelines recommend surgery for cauda equina. If you go into a hospital with cauda equina, you should have surgery, but it's not based on randomized trials. And if you just look at the studies, they're all retrospective studies. You almost can't see a difference, right? Some say there's a difference, some say there's not a difference based on the amount of time from diagnosis to operation. Just quick things, right? How can you eliminate, bias, random sequence selection bias? So the first study that ever showed benefit for epidural to prevent phantom limb pain after elective amputation, they randomized people based on date of birth, and that's the most positive study, right? You can have high allocation concealment. You can have, block randomization with high numbers. But I will say that there are some IRBs that say, no, we don't want these people randomized in blocks of 16. And then for a study that, that I reviewed, a big randomized trial, they randomized people in blocks of 4, to different things, which means that at least 25%, and sometimes it might be a lot more than 25%, 50%, you're going to know which group that person's going to receive. You want to avoid the detection bias or blinding of outcome assessment, like I say, and if there are some things that are not possible to blind, like interventional studies, and there are some for surgery. or where blinding can actually mean that you really don't have a true placebo and you want to avoid like selective reporting. I show this slide. You know, there might be more studies for pain than almost anything else, because studies for pain are published in every surgical journal, right? Like almost every journal, right? Pediatric journals, general medical journals, just everything, right? Pain affects everything. And so you have, you know, like hundreds of articles each month, and almost all of them are positive. They have something by this is one, Finelli, but there's another thing also, right? So pain, psychiatry, psychology, these things with subjective outcomes, a much higher percentage of studies are positive. So if we have like 200 studies or 200 papers a month, and almost all of them are positive, nobody should have pain in the whole world. It's like, you know, putting money in a bank, right? And just interest should compound cumulatively. But you don't see this. What you see, and it's really hard to see, is the prevalence rates actually decrease. And disability increases, right? So something doesn't make sense. The only thing that really affects disability is kind of the economy. If the economy is not going well, there's more disability. The economy is going very well, there's less disability. And, you know, negative studies, there's a lot of publication, right? They're not submitted, especially by industry. And they're, even if they are submitted, they're less likely to be published, and they're less likely to be published in good journals. And then when, you know, the group six, you know, the neuropathic pain special interest group started to revise their guidelines, and they looked at studies that were not published, they went on databases, it changed what they did. And they said that, you know, that if you're just looking like on PubMed or something like this, you're going to really get overestimation of treatment effects. Look, it's very, very hard to reproduce data. Lots of companies, without getting into these things, right? They've looked at like reproducing data, and they're drug companies, right? That's important, right? Because you can't just have one positive trial and get something approved. You have to have multiple trials. So they try to reproduce things. And just saying, and I will go over this, right? A p-value of 0.05 doesn't mean that there's like just a 5% chance of an error. It's not this, and I will show you things. So, like I said, other studies, when you look at cancer studies, when you look at oncology, women's health, cardiovascular research, very few studies are reproduced. And this is a big thing with industry now, right? Like, because these things are insanely expensive. Like, how much money do you think Vertex spent, like, just on their advisory board meetings? Like hundreds of thousands just on the advisory board meetings, not to talk about like these you know, the studies, right? So you want to identify like drugs that are not going to work really early on, because you'll save a lot of money. And this is from The Economist, right? You definitely don't see this in pain, but let's say you had 1,000 hypotheses and 100 which were true. Now this is a perfect world, and we don't live in anywhere close to a perfect world, right? If we have a false positive rate of 5%, right, because that's what the p-value is, the most common thing, then there'll be 5% of 900 negative studies. So you'll have 45 false positives. I never power studies at 80% anymore, but lots of people do. If you did, you would only confirm 80 out of 100 true positives. So if everything is perfect, and it's not perfect, right, you're going to see as a researcher 125, right, positive hypotheses, but only 80 of these are true. So that's the issue with, you know, p-values. And, you know, I had a good friend who was very high up in the pain world in the DoD. He was the first pain consultant to the Army Surgeon General. And you say, why don't we just do this massive study with, you know, 1,500 people looking at epidural steroid risk? And, you know, the problem is you expose patients to unnecessary risk. And then when you have like these large, very, very, very large studies, everything becomes statistically significant, and it might not be clinically meaningful. And you also, like I say, the costs are much higher, and you're a lot more likely to not, you know, to not finish a study. So like I said, the p-value of 0.05 doesn't mean that there's a 95% chance the null hypothesis is false. It also doesn't measure effect size, the importance of findings. And when they look at like population genomics, I mean, look at these things. I don't even know what 10 to the minus 8 is called, but it's really small. They use these incredibly small like, p-values. So a lot of people, there's talk of like moving p-values to 0.005, so just like a decimal place over. It would be a problem for interventional pain because you look at the randomized trials for pain and they're very small numbers. So, you know, lots of people see things in terms of black and white, just look at politics, but look at the FDA. We've looked at like this liquid capsaicin, you know, even for using it in Ukraine. But like the Centrexion's, you know, last two trials looking at this, the liquid capsaicin, which won the Nobel Prize, you know, the p-values were like 0.06 and 0.07. Like the FDA doesn't care. Just it's negative. And if it's positive, it's positive. And so it definitely would have like real world implications. So look, for pain, you know, just in medicine in general, you know, it's estimated that 15% of conventional medicine is evidence based. And for integrative medicine, for people who do this, it's less, and it's probably even less for things with subjective outcomes because no one even knows what really is evidence-based. You look at these systematic reviews and they just diverge dramatically. But what is evidence-based medicine, right? So if you look at the original like description from David Sackett, right? Like, yes, you're looking at like clinical trials, but you're also looking at like what the patient wants, and you're looking at like clinicians' judgment and experience. So it's this little interface. Again, blinding is a big thing, right? Non-blinded assessment in randomized trials exaggerates the effect size by 33%. Even if the study is considered to be blinded, right? And then you don't assess blinding, it's still 13 to 25% more likely to yield positive results. But the effect size more than doubles for subjective outcomes like pain. It also increases heterogeneity. So these are just a couple things, right? Spinal cord stimulation, even high frequency, right? Which people say you could do a double blind study. People can't feel it. It's sub-perceptive threshold. That's not true in a lot of people, like 25%. PNS studies, right? I was involved in these studies. You can't really blind. People know. Ketamine, very few studies. We know that we can't blind. We're not even assessing blinding for our DoD studies. Radiofrequency ablation, we've done this, right? And we've been able to blind studies. Scope is blinded and pulsed radiofrequency we did, but it's really difficult. Like we went in, we put the needle in, we moved it around, and then the doctor leaves the room. And then somebody else has to do it. But you can still kind of see, like in our study, some people got steroids and sham radiofrequency, and some people got pulsed radiofrequency and steroid. And even if you go back into the room, you can still kind of, if you were really looking, you can see. Epidural steroids are very hard. You can blind them, but if transforaminal injections are more efficacious than intralaminar, but people feel it down their leg usually. And if you were to do an intramuscular, which is the true placebo, because remember, even epidural saline or local anesthetic is a treatment. People will know the difference, right? Because most people will feel pain in their leg, for an epidural injection. And for intramuscular, it's a tiny needle, they won't feel anything. Vertebroplasty, like I say, the issue is that you can blind it in most people. Well, not in most people, but you can effectively blind it. The thing is that when you blind it, people are getting septblocks or branch blocks. Most sham controlled surgical trials are negative. This is the thing, and like I say, there's a lot. Very, very, very hard to show. Allocation concealment, you can look at baseline data that's not equivalent. And I remember we had this in a study and we actually reported p-values in the journal, which was Pain, said we don't want p-values in baseline data. So it goes back and forth, but still you should report. So in this systematic review, they looked at 234 randomized trials published in 4 top journals, and 56 reported adequate, 26% unclear, 18% inadequate concealment. But the p-value for the adequately concealed trials versus the inadequately was statistically significant by itself. You know, in intention to treat analyses, like I say, you know, randomized trials, very hard to blind. Intention to treat analyzes subjects regardless of appearance. So you're really, what you're doing is you're not measuring the effect of treatment, you're measuring the effect of randomization on patients. So it dilutes treatment differences. It could include people who don't get receive treatment. So if you look at those big sport trials, right, the New England Journal of Medicine, the intention to treat analysis were negative on some, but the per protocol, like if you just looked at people who got surgery, they were positive. But more than 40% of people were not adherent. They had other treatments, so it's really hard. So in our big $20 million NIH study, we have kind of a problem, right? Because we're randomizing people to get radiofrequency ablation, nerve blocks with a very, very long-acting sustained release local anesthetic and sham radiofrequency ablation, or intra-articular injection. And these things are really expensive. I mean, it's thousands and thousands of dollars to get radiofrequency ablation. So insurance is supposed to pay. We're doing the study to see if it works. But like almost 20% of people couldn't get the intervention because their insurance wouldn't pay. So they're randomized. So for this, you know, then the NIH agrees, you know, intention to treat can't be used as the primary analysis. It has to be co-coded. Like I say, and why do you want to do like intention to treat analysis? Well, let's say that you're trying to look at a drug that decreases weight and you went to like Overeaters Anonymous. Well, people are going to lose weight there, right? Because they're going to Overeaters Anonymous. They know that they're overweight. They're trying to lose weight. And then you do a placebo-controlled trial. Now, you know, people who don't lose weight are not going to, they're going to probably drop out. They're going to see it different. They say this doesn't work. So if you're just looking at the people who show up, this is why you have to do intention to treat, and you have to be very conservative. Like a lot of these sensitivity analysis, they consider all dropouts to be treatment failure. So if you're just looking at people who, you know, show up for treatment, right? A lot of people who get the placebo, they're still in Overeaters Anonymous, and they want to lose weight, they're trying to lose weight, and you're going to see a disproportionate percentage of people. So there's a difference. So I'm kind of almost done. So, you know, again, I brought up the blinding dilemma. You can't always blind the interventionalists. This is leg pain for transforaminal neuritis or feeling burning for radiofrequency. These psychomimetic effects with ketamine, and in fact, ketamine, the beneficial effect for both pain and depression, anxiety, PTSD correlates with psychomimetic effects. So you want people to actually feel it. You don't want them to avoid, right? There's lots and lots of different ways. I think I might have handling, yeah, so I think, I see, I went, I skipped a slide. So I'm going to my other thing. So anyway, this is the second to last trial. So how do you reduce dropouts in pain trials? Well, you can target a condition that's not adequately served by treatment, so people will come, right? It's all out of cancer. You can allow the use of rescue medications and crossover, but if you allow the use of rescue medications, how do you know if it's from the rescue medication or if it's not? And so the best thing is to have people stop these rescue medications like a week before, or to put a limit on them. You should allow a flexible treatment regimen that accommodates individual differences in efficacy. They have a lot of these like new adaptive designs where you just drop trials. So like our DSMB we have 2 phases to scope that knee osteoarthritis. And they said, we want you to drop this arm in this phase because it's clear that it doesn't work. But these things will happen like kind of naturally. You can do enriched designs. You know, the problem, like we're saying, is it really reduces generalization, you know, and you can shorten the follow-up. But again, we really want in real life to see if people have benefit in the long term. So logistical and practical concerns have led to evidence gap in pain medicine compared to other specialties. It's greater for interventional treatments. It's important to pay attention to design, like maybe allowing, early crossover for controls, comparative effectiveness studies. So we're allowing like crossover for a PTSD TBI study that looks at stellate ganglion blocks and ketamine. We allow crossover at 1 month. This is because this is what the DoD and the VA want. Look, now it's hard because pain is less lucrative than anesthesia. So there's this shrinking reimbursement pie. And so we need to have better research, for patients. And I think, like I say, it's very important. We want to establish efficacy that's hard in these big, rigorous trials, but they often don't reflect what happens in real life. And so then we need these database reviews, effectiveness studies. Talk is finished. Sure.
Thank you very much. Do we have any questions online? Any questions online? Not. Any questions from the audience?
Yeah, sure.
Thank you so much for the wonderful talk. And a lot of contextual factors you mentioned may impact treatment outcomes. So my question is really about the prior experiences of treatments for participants. Because you say physician-patient interactions may play a role, and also participants' own characteristics may play a role. When considering more dynamics about how participants may experience different kind of treatments, my experiences within chronic patients is often they come in the lab and they will say like they have done this and that, but none of them are actually effective. So how that can be controlled and how that may be considered into clinical trial design. I'd like to hear your.
So I saw like a new reference last week, but I can't remember, where they looked at outcomes based on the number of treatments. And if you looked at, I showed you guys that difficult paper, the difficult patient paper that we published in January in Mayo Clinic. We look at that also, but it's categorized, like no treatments, 1 to 2 treatment, 3, like more than 5. But it's a measure of disease burden. So we talk about like intersectionality. Like, people who failed more treatments, they have longer duration of pain. They're more likely to have psychopathology. They're more likely to be on opioids, right? Because they've had pain for a long time and nothing works, so somebody puts them on opioids. And they also have lower expectations. It's kind of like a joke, right? If someone came into my clinic and I was seeing them for 10 years and they came in with foot pain and I gave them something and they got better, and they had arm pain and I gave them something and they got better, and they had a headache, and probably the 7th time they keep getting better, they're going to get better. And then when you have these people who come in and they fail 15 treatments, like I don't even want to treat them because it just like, what's the chance? I mean, it's not only that why is the 16th treatment going to get better, but then you start to go down to the 1st, 2nd, 3rd, 4th, 5th, 6th, like 10th line treatments, like after someone's failed 15. So it's really hard. That's why you don't put these people in efficacy studies. The problem is a doctor is, like if I were an insurance company, and this is one of the things that we have a review on this that'll be coming out. We just sent a revision yesterday in BMJ Medicine on outcome predictors. Like if you're an insurance company and somebody is out of a job, they have secondary gain, they're on opioids, they're depressed, they're not working, so their husband or wife is leaving them, they're not sleeping well because of pain. I don't want to pay for a procedure for them because I know they're going to fail. They have every single risk factor. But if you're like the doctor who's seeing this patient like you really want to treat, because the patient's coming in, they say, I really want to get back to work. My wife is leaving. I'm on opioids. I don't want to be on opioids. I can't sleep. I'm becoming depressed. Like this is the person you want to do a procedure on. So you have this, it's very tough to kind of figure out what to do.
You want me to read or would you like?
I can read. Oh, I know. Hi, Wayne. So it seems like the more rigorous the study, the smaller the effect size, the decline effect. Are we doing research for scientists or for patients or for industry? Should we not find out what type of evidence patients want and are happy with and do more of that type of research? Who's running the research show? So this is a big thing now, right? Because now I don't know if it started with PBO, right? Where you had to have like this, I had a PBO grant, rejected once because like I only had like letters from 3 people where everybody else was like having these big, huge, enormous like stakeholders. But even for like our NIH, we had like 10 patients. Like they put 10 patients from all over the country in a room. And like they really affected like what clinical trial we were doing. And for this BMJ medicine paper that I was saying outcome predictors for pain, it took over 3 months to get something back from them. And you know why it took 3 months? Because they insisted on sending it to a patient reviewer. They said, we want like a patient perspective. That's really important, somebody with lived experience. But look, if I were a stockholder in a company, I just want the study to be positive and I just want it to be approved. And like I say, as a taxpayer, I don't want that guy with depression and sleep problems and secondary gain who's overweight and sedentary. I don't want to pay for him to have a very expensive procedure, but if I'm his doctor, I do. It's a, it's a balance.
James?
Is there like is there a possible avenue to establish like how we can treat those people who have failed the 15 other treatments? Like that is a specific subset of the population. How would you go about figuring out how you can improve their lives?
So I will defer here to Jan and Luana. I think it's managing expectations. So what we try to do, and people don't like it, is to say, look, you've had this pain for 18 years, it's 10 over 10. You've tried 18 different treatments. You've had this many complications. I think the goal should be to improve your life, your sleep, kind of what we would say functional restoration. And your goal shouldn't be complete eradication of pain. So you have to really, really manage expectations. I mean, like seriously, if you failed 15 treatments, and the first and the second, the third and the fourth, you tried all of these things. And then you're looking at like weird things like reflexology. They're probably not going to get better and they have to pay for it on their own. So I think it comes down to like some of these things, like we're saying, managing expectations, setting realistic goals. Like, I want to sit through my kid's baseball game for 2 hours.
Thank you. I think we are over with time. Thank you very much to all of you who are online. And I hope to see you again April 28th. Thank you to Dr. Cohen.